good morning and welcome to this plenary session. It's an exciting hour, and thank you so much for setting this up because it's quite timely. We're going to be discussing intra-Africa trade challenge and within the healthcare space. And I have with me I say the innovations and the experts and the professionals. I always use the term crazy, doing crazy things all across Africa, because anything, if you can innovate in Africa, I must say you must be out of it because of the challenges we all face. And it's not just about, most of the time we have governments that invest in infrastructure, they invest in technologies, but you hardly see governments investing in health. So today we're looking at healthcare, and we're looking at it from the angle of how do we increase the availability and affordability of genuine pharmaceuticals, vaccines, medical devices and diagnostics, and of course, biotech. How do we go into telemedicines? What is happening within our countries where we're based or our regions? But then looking at the emerging, the emerging trends. One is COVID that has taught us a lot of lessons why we must begin to look inwards. So one is the lessons we've learned from COVID. The other part is looking at the Africa continental free trade area, the agreement that is supposed to transform a lot of things, even mostly in health, local manufacturing. We are also seeing the emerging from the Africa Union, the Africa Medicines Agency. All these are things that we look at within Africa that are going to shape a lot of things within the digital space, how we use data and ICT across the value chain. So just teasing your mind in there, I want to start off with that before I even introduce myself. So having said that, I hope we're all ready for an exciting session, all the panelists that I will be introducing shortly. My name is Azuka. I am the Chief Executive Officer of Africa Resource Center for Excellence in Supply Chain Management. We are based in Nigeria, and we are a resource center that pulls in private sector resources, setting them up like we used to say a library, platforms, whereby we want them ready in Nigeria, for instance, so that government can access readily those best practices, models, tools, technologies that they can leverage to strengthen healthcare delivery. So you can understand why I'm excited about this session and looking at it from a continent approach beyond the country where I'm based in. And of course, excited to have the expert panelists in the room. So thank you very much. I will start by introducing the people that are in the room with me. I have with me Dr. Amit Taka. Dr. Taka is a pioneer in the integration of private sector within the healthcare system in Africa. He actively supports governments, corporates, health organizations, and development partners to foster effective public-private partnership initiatives towards improved health outcomes. He is the executive chairman of Africa Health Business, president of Africa Healthcare Federation, and the immediate past chairman of Kenya Healthcare Federation. He has served as a director at Lumira DX, 7Cs Technology, Amref Flying Doctors, Action Aid, and Ganima Limited. So I will want Dr. Thakker to say something to us. Dr. Thakker, to have you here.
Thank you, Azuka, and thank you to the fellow panelists and the organizers. It's a pleasure to be here. Looking forward to the panel. Thank you.
Fantastic. I also have with me Babusi and Nyoni. And please pardon me, we Africans, we can only pronounce most names within our...
You're doing a good job. You're doing a good job.
Just in case, I don't get it correctly, but I just bear with me. But Babusi is, he is the CEO for Sila Health, a global social enterprise that helps people anywhere access healthcare on any mobile device by harnessing machine learning. Babusi founded Sila Health after identifying an opportunity for artificial intelligence to fill the institutional void created by poor healthcare systems in developing economies. So, Babusi, if you could just say hi to everyone.
Hi, everyone. Greetings to my esteemed panelists and to you as well. Thank you so much for having us on here, and I'm looking forward to the conversation.
Fantastic. And of course, my own brother, Deji Ogunye, who left us for the show. Deji, I hope you're still in Nigeria because I see you all over Africa. So Deji is Chief Supply Chain Officer and MD Nigeria, Mpharma. Mpharma, he's responsible for operations across 7 sub-Saharan African countries. He's a seasoned supply chain professional with over 19 years diverse experience from managing a full spectrum of functions in global multinationals on 2 continents. His industry experience cuts across pharmaceuticals, consumer electronics, management consulting, and FMCG verticals. He has also led multiple tax-effective supply chain and operations transformation projects. So Deji, good to have you here with us.
Thank you, Azuka. To the panelists, it's a pleasure to be in your midst. I'm actually looking forward to this conversation. It's been a while. Azuka mentioned that we have a history, and I'm still in Nigeria. I'm still in Lagos. I'm going nowhere. I think the chaos is exciting for me in sub-Saharan Africa. So I'm not running anywhere anytime soon. So it's a pleasure, everyone.
Thank you, Dayasi. Here with the trend of everyone, I see things on LinkedIn. I'm like, oh, my brothers and sisters, why do you do this? People say, oh, I now have a Canadian passport. I mean, I'm like, okay, so who is here? But also we have with us Yusuf, Bilesanmi, founder and CEO, Shifa Technologies Limited. Yusuf is a serial entrepreneur, having established Asia Ice Limited, a solar-powered refrigeration and cold chain service company, and Shifa Technologies Limited, innovators and manufacturers of the SheVent, a non-electric, non-invasive ventilator. Yusuf has a background in energy and infrastructure, working in clean tech, smart grid, and digital factories to foster decarbonization, decentralization, and digitization of energy across the value chain to enhance operational efficiency and maximize profitability for businesses and wider society. So Yusuf, it's good to have you here with us.
Thank you very much for having me. I was just feeling it when you were speaking to Deji and talking about who's here, who's not earlier. So yeah, it's indeed a pleasure to be here with you all. We'll come to that. Yeah. We'll come to that.
I think why these panels, these conferences are very useful is a lot of times, you know, many of our young people do not know we have these things available. We are innovating, we're serial entrepreneurs, we're facilitating and brokering a lot of public-private partnerships. We are creating job opportunities. We are adding value across the supply chain, all through the supply chain. But again, like I said earlier, COVID kind of proposed and redirected everyone. So this is why, you know, I'm happy those that set up this conference, I'm happy that they are looking at it from the digital space. So I go straight to Dr. I mean, everyone, the speakers, I've already introduced you, so I will just go on straight to the questions. And I'll start with Deji, not because we have history, by the way, but I think I want to understand, what is Mpharma? How is Mpharma using data and ICT across the value chain? From regulatory approval to forecasting, negotiation, and timely supply of pharma. How are you dealing with that in Africa? And again, remember, we're talking about where you are, but looking at where we are going with the free trade agreement, how are you going to leverage that? So go on, Deji. Yeah. You're on mute.
I'm sorry, Azuka, can you repeat that again? Apologies. I think something happened to my system first. Hello?
I can hear you.
Okay, yeah, okay. I'll wait for Azuka to pose the question again. I completely, she's frozen. Okay, I guess we'll wait a second. I hope everyone is taking a deep breath from the drop kick that COVID gave all of us in the last 2 years.
Yeah, we're still taking that in.
Yeah, I can only imagine. I can only imagine. It's been, I think, from a supply chain standpoint, it's we've taken off the proactivity hat, and we're so reactive because the headwinds are changing so quickly and so broadly that it's actually making us now start looking at a 5-year horizon now and start planning. I mean, I think the horizon we're looking at pretty much annual. We're looking at 2 years. Now we're looking at 5 years, and the possibilities. What can go wrong is what we're looking at right now.
Yeah, interesting. That's the question Azuka actually asked. She wanted to understand, what kind of data are you gathering, and what does that inform you about forecasting for the business, and rightly said, that's
so I mean, and that's
Azuka's back. Let me let her.
Okay, hi Azuka. Sorry, the question again.
Africa and power surge. I just got cut off. That's the reality of Africa. So looking at my situation where I just got cut off, how is Mpharma dealing with this, our continent, and how are you doing it in this country using your technology, ICT, to make sure across the supply chain, you are able to deliver efficiently? And like I mentioned earlier, sorry about that, I was cut off. Looking at it today, but also looking at the opportunities within the free trade area. How are you looking? Thank you.
Well, I mean, thank you for that, Azuka. So one of the things we've done in Mpharma is pretty much focus our investments on ICT, actually building out our product and engineering teams. To that end, the conduit that we use for collection of data is through our proprietary software called Bloom. So Bloom acts like a POS system, also aids in our inventory management, from our inventory management also to collection of patient data and statistics across our markets in sub-Saharan Africa. So we've created a platform that easily integrates to our ERP systems. We use SAP primarily, and we use this pretty much anywhere from our sales operations all the way to data collection. Now, how does this guide us? I will take you into from private practice to public space, because right now we've moved into one of the recent collaborations we've had is with the government of Gabon to transform their central medicine stores. What you find, especially in that space, is that there's absolutely no data. When we got in there, we could not tell what the last patient at a certain hospital in Oyema, Kojontel, took in the last month. So we had to pretty much build everything from scratch. So that is why, I mean, that's, that was pretty much our value proposition to them. First of all, we need data to be able to determine what the disease outcomes are, what the disease prevalence, patient behaviors, and this would help guide our procurement of molecules, what particular molecules we procure from where. Because again, when you're dealing with sub-Saharan Africa, you have to look at not only the product efficacy, but the thermostability data of the molecules you bring in to ensure, of course, you are able to store enough inventory based on the shelf life. Because for imports coming to sub-Saharan Africa, I mean, from manufacturer to landing at the ports, you've lost close to 25% of available shelf life already. So you have to find a way to maximize it. So we're looking at products that primarily would treat the particular disease and also enable the government or the private sector company like all ours to avoid expiries, etc. So from a data standpoint, it starts from our proprietary POS system, which is Bloom, and we use that to collect data. From a forecasting standpoint, this helps us determine how the patient behaviors, as I said, and also we're able to get data on disease prevalence. So we know where we get the spikes in what particular period from a seasonality standpoint, where malaria climbs, where we have a spike in cases of HIV, etc., especially based on our dispensation data. So we're able to actually track this. Now it varies across countries. I mean, in Nigeria and Ghana, you see different swings. For example, one of our vaccines, one of our treatments that we use for snake bites is looking at how, when we do our heat mapping, is bright red, especially in the rainy season in the north of Ghana. I never knew that until I started seeing the data, right? So this is how we engage the manufacturers as to what we need to buy, where we need to buy it, where the right products need to be in what particular country. So that is, I mean, just a general answer to that.
Thank you very much. I mean, what I'm hearing really is that Mpharma, you've been able to figure out what kind of solution you use that has for you getting your commodities to the end user.
Yes.
And it has worked so far. I mean, Nigeria, Ghana, West Africa. Then looking across beyond that, I want to just take it to Dr. Thakker. Dr. Amit, when do you think, if we're looking at this free trade agreement, when do you think we can get one functioning regulator and licensing body across Africa, particularly for technology? Do you think we are going to see that in the nearest future, or everyone come with your solution, what works for you, or it won't affect the value chain?
So yeah, thank you, Azuka. You saw the press communique on the 9th of November from Africa Union. It's actually 17 countries. They were waiting for 15 countries to deposit the instruments. So the 17 countries have done so. Another 24 countries have signed the treaty but have not deposited the instruments at the Union. The 15-country mark has been reached. So I think this is the year of celebration. It is actually the inflection year for Africa and supply chain. It's an incredible year. This is the time where I believe we have passed the first hurdle, and the system of setting up Africa Medical Agency is now going to be in place. The Commissioner of Health, Amira El-Fadil, Michael Sidibe, Margaret Angama, and many others have worked very hard, and many people in different countries have worked very hard. So I believe we are at the most important inflection point. It's going to change the cost of healthcare. It's going to change availability of supplies. It's going to change intra-Africa trade from the 17% as we try to achieve what Europe does at levels of 70%. And the people who are in the healthcare system are going to take advantage of this. Manufacturing will change. All the stumbling blocks. We had 55 borders that made 55 obstacles of paracetamol moving from one country to the other. All those are going to be lifted. Imagine it's going to be 55 times easier. Like you asked earlier, how long will it take? That's a good question. I think member states have been asked to apply. Those who want to headquarter the agency, the letters are already out. I'm thinking 6 months to a year. They will have bureaucracy before it's announced. I'm hoping it's fast track, but I see light maybe by end of next year to have a structured and a functioning. Then the implementation may take 2-3 years. So in say 4 or 5 years, we will have a dramatic reduction in costs of supplies and a dramatic improvement in availability.
Fantastic. I like projections, and again, instruments dropped and we begin to implement things. Africa, always Africa. I hope we can be more proactive. But I'm going to go on straight to Yusuf. Yusuf, clean energy. I hear frugal innovation in Africa. Then I go to COP26, the whole world talking about climate, clean energy, and and I look at my country, Nigeria. You talk climate, people say, let me eat first. What are you talking about? Cleaning, whatever. I don't even have food. Climate change is not our issue. How are you dealing with that? How are you using technology? How are you looking at what the global community is saying, calling for everyone to go clean? And I like frugal in Africa, good, if it's going to be affordable. So tell us, technology, clean energy, frugal.
So
what do you see?
Yes, and really thank you so much for having me, and really brilliant words from the earlier speakers. Frugal is important for us to have an equitable access to healthcare, because most of what we have today is usually imported, the cost of logistics, the cost of operations, and that's why it's not equitable, because when the hospital has to put together all the costs that goes into delivering that service to that individual, it becomes more expensive than they would have had it if some of those materials were locally accessible. Now, look at the situation earlier. There was a power cut, and all of a sudden you were out of the network. That's the reason why we ensure that when we're designing for the ventilators, we focus on 4 key primary objectives to ensure that it is non-electric, because it's a sad story, but a lot of people have passed on in Nigeria and other African countries just because of the power cut. Doctors have had to, administer, critical care, with a torchlight, and the thought of all this and what that means for somebody in respiratory care, which is just that little grasp of, hope they have to live. And if there is a power cut, most likely, it will either deteriorate the condition they're in, or unfortunately they might pass on. Hence, a non-electric solution was key for us. Second was access to oxygen, right? So a lot of the situations that followed in markets like Malawi, Nigeria doesn't really have so much of a oxygen supply problem, because there is enough supply from companies like Liquid and Bilesanmi funded oxygen concentrators. But when you look at other markets like Malawi, they are usually cut off supply, and most of the cases, and even in India as well, not just within the continent, but we're looking at a global space. But ability to build and supply and produce things locally is what is where we need to be. And when you look at a fact and you ask yourself, okay, what about the feasibility of being able to source materials from within the continent? Because almost it comes from outside the continent into the continent to source stuff, produced in Europe and sent back to us. I think we are at a very, very defining moment, and I'm not in a rush for it. I'm interested in seeing how this evolves by 2030, right? We need to take our time. We need to grow in a model that incorporates trust and togetherness and is sustainable in longer into the future than just picking onto the next thing, which is fair enough because we're catching up. But leapfrogging is good, but a lot more needs to happen internally for Africans to work with Africans and get more done. And there's so much we can source from within our borders, and this creates pockets of wealth across the continent where markets where a particular material has been sourced, you can create jobs in just sourcing that material. There's a model that Japan usually adopts, which is that each prefecture, right, each city has a product that it's producing. We can do that at the state level in Africa, and there's just so much resource that these markets do have. But what's really missing is the manufacturing capacity. Africa. So it wouldn't have the resource. It's another thing to mine for the resource. It's another thing to get the resource, right? Then it's something else to now put all that resource together to make products that you can then get to the market. That value chain itself, you would find that even the same, you share the same supply chain with the manufacturer with a supplier in Africa. A Chinese company can still source that material faster than yourself, process it, and get it to market faster than ourselves. And that is the reality. We need to, as much as we invest significantly in data, a point where we need to invest so much more in manufacturing and local supply chain networks for a factor to be a success.
Yeah, I hear you. I mean, I was already ready to go when I listened to Dr. Thakker, who said, now is the time to hit the street. You know, we have this opportunity. Now I listen to you and you're telling me, let's take our time, let's look inwards, we need to focus internally, strengthen our manufacturing. And I'm like, oh my goodness, who? But I want Babusi to come in here now, because I don't know how Sila Health is looking at it. Considering that we're looking at quality of care, access to quality of care. And I heard Deji mention that Mpharma is already providing access to the commodities. They have put in place technologies that can get the commodities to where people need them. Now, Sila Health is trying to do where people getting access to the services. The services, they need consultation. And we know how important it is in Africa. Or like people leave Africa to go to India. They leave Africa to go to America. You know how this health tourism has gone. But with opportunity to access service delivery across the continent, particularly with the kind of regulatory system that will enable that, how do you think you can scale as Sila Health? Thank you.
Thank you, Azuka. I think to answer that question, I'd have to start with how we build Sila Health, which is, having to take into consideration insights from the ground, knowing that, Africa has the fastest growing internet adoption, internet penetration by comparison is growing at a faster rate than anywhere else in the world, which meant that if we were to create something that was going to scale across the continent, it had to be something that harnesses the internet. And we also knew that the region also suffers from an unnecessarily high cost of internet, with an average of about just over $6 per gigabyte. Sub-Saharan Africa has the highest price for mobile data. So we also knew that what we were building had to be something that was available on low-cost platforms, platforms that didn't take up too much bandwidth, that were accessible to people across the economic spectrum. And also looking at what it meant to build something within the e-health space that connected patients to doctors. We were also cognizant of the fact that doctor-patient ratios on the continent are on average one doctor for every 5,000 people. So what that means then is that we can't connect the same finite amount of doctors to a growing population. And we had to make use of scalable technology like machine learning to reach patients at scale. And what we built was a machine learning model that handles low-level interactions with potential patients. And what it essentially does is glean information around symptoms that they might be presenting, and also through a formulaic approach, present a prognosis on the basis of the likelihood of someone suffering from a disease, specifically looking at the prevalence of these diseases in Africa by age group, by gender, and also by looking at risk factors like lifestyle indicators that include, whether or not someone drinks or smokes and all these other things. And we launched in 8 countries initially because we launched as a fully autonomous platform. So we were not connecting patients to doctors directly. We were working solely with the intention of allowing people to have their low-level questions regarding their health answered instantly on platforms like WhatsApp and SMS and Facebook Messenger. Because for a lot of these people, the luxury of going onto websites like WebMD to get a general question regarding your health, something that's not life-threatening, is something that they can afford to based on the cost of the internet. And for a lot of people, accessing the internet is essentially accessing WhatsApp and Facebook. We had to, in making considerations for localizing this in the different countries, we built a separate machine learning model that handled small talk. And there's a Financial Times article that documents this. But the idea there was, how can we invest in localizing the solution to, in some way ensure applicability and appeal in every locale we're focused on. And we also knew that every place is different, and what might be like social quirks to someone who is not from an area can essentially make or break a solution whose success relies on the fidelity of its conversational interface. And looking at how we have approached, how we can enable people to access quality consultations, and as you asked as well, even if these are cross-border consultations, the first thing that we wanted to answer is, how can we use digital tools to bring transparency across the value chain and ensure a level of accountability at every single touch point? So when someone books an appointment with a doctor, how do we ensure that the sponsor can attest to the quality of care that they've paid for? How do we ensure that the outcomes for the patients are as high as they can be? How can we leverage, predictive modeling, for example, to look at who might drop off from drug adherence, for example, and how can we use the ecosystem of tools and products we've built to improve quality of care, as well as improve service delivery for the providers on our platform. And we did a really good job at achieving this, but now looking at how we can apply this across multiple territories, I would say, as an entrepreneur who's of course not well-versed in the regulatory landscape and policy formation and implementation, speaking almost vernacular, I think regulations that encourage innovation instead of stifling it are what we need in order to enable people to access quality consultations and spread this wealth of talent in the medical space, to allow people who are in places that don't have that much resource in terms of ability to connect people to basic healthcare to be able to access it. When we look at data privacy and the legal implications of providing care across jurisdictions, I think as a technology forward company, we've been having to self-regulate in order to ensure that while we are moving at the speed of the problems we are finding, we are doing so in a way that should we be regulated in future, we wouldn't have to pivot too much in terms of our model and our operational, standpoint. And I also think we need, region-wide conventions on how to administer care and how data privacy policies factor in cloud-based storage and enforceable encryption protocols. Because I feel like as a continent, we're still lagging behind in what it means to, ensure privacy at a certain level, what it means to share data, while completely ignoring what it means to administer care virtually, what it means to be, physically in a practice where, doctors can now, in a sense, conduct consultations from, the privacy of their homes and doing so with patients in their homes. So what does it mean then to store data securely and privately when the rest of the world has been using cloud-based storage and encryption protocols? So I think there's still a way to go. I can speak confidently on what the situation is on the ground in Zimbabwe, which is where we predominantly operate. And I'm sure it might be different in other countries, but I'll just put a pin in that for now. Continue the conversation.
Yeah, I'll come back to that because what I'm hearing, and it's coming out strongly, is the issue of data security. By the time we begin to cut the red tape, I can already imagine what would be, the fears, and I'm looking at it both from the public and also from the private sector. And these are some of the things people are concerned about. And also going back to what Yusuf said, if we don't strengthen it internally, where we have weak manufacturing, then we already begin to see the trade opportunities and we begin to ramp up. How do we ensure quality? You know, so again, some of the other emerging things coming, like I mentioned, the medical agency, the medicines agency. How does that help countries that are that have their own agencies in country? By the time AU would have these economies of scale, what does that do to Mpharma? What does that do to drugstore? So I move back to Dr. Thakker. Dr. Thakker, tell us, I want to, what challenges are you seeing with some of these red tapes that will be cut? You know, you say we are ready, it's all to make sure to strengthen the regulatory. Then once the instruments are there, what are the challenges that you're seeing already across countries, you know, when it comes to import, export, healthcare products and services, the issue of maintaining quality? And is there a way, what can technology do to make, you know, to regulate and to ensure quality is not compromised?
Sorry, before you go, I hope you don't mind, I want to add another question to Dr. Thakker. I'm actually excited to have him here. On the free trade agreement, right, moving across sub-Saharan Africa, one of the main things I'm really concerned about is some of the government policies that can ruin the initiative and the purpose of this particular free trade movement of drugs. For example, Nigeria, a few years ago, unilaterally took a decision to shut the border. Even though within ECOWAS, we have free movement of goods, we are now seeing retaliatory initiatives from Ghana, charging duties on certain items as a result of the significant financial impact they suffered, because Nigeria being the biggest market, they had to suffer it. In some cases, they had to smuggle commodities in, etc. So they are now retaliating now that Nigeria has opened the borders. How do we, from an Africa trade and healthcare standpoint, influence? Okay, we know how our governments are, but how do we influence that, prevent that from happening and getting them to see the value of ensuring these free movement? This is in addition to what Azuka, sorry, I just got excited.
No apologies. This is the relevant things. Go ahead, Dr. Thakker.
No, these are real questions. And first, let's begin that it's not easy, right? India is 1.3 billion people, and Africa is similar, but India has one regulatory process, and here we have 55. So you know, when people start comparing, you have one law that applies to 1.3 billion. So using the same perspective, but have regions done it well? Have we tried ECOWAS, EAC, SADC? You know, they've been trying. When ECOWAS was being formed, you remember all the worries and scare, and now WAHO, which is present there, they're doing a decent job. I must say they've collaborated, they've come up with some things. So look, let me just say that it is a long-term process, but a journey of 1,000 miles begins with the first step. And I think we are talking about our future generations. That's why when you hear MDGs and SDGs, we've come with our own Agenda 2063, and we are being realistic. You can design something in Washington, DC or in Geneva for Africa, but we in Africa must design our own plans. Who set those targets for us? Who decided that this is what we have to achieve? Who decided that that's what we're going to achieve? And this is what we're going to be measured with. It's now Agenda 2063 with 20 goals. If you've seen the 20 goals of Agenda 63, it's a 4-step process. The foundation is 5 years between now and 2025, right? From 2025, we have every 10 years to measure where we're going. And all this takes a process, including Nigeria, Ghana, duties. Every country is a sovereign state. If you remember, they were all planning to become prosperous. They're all thinking of what they have as their own model. And now to start balancing, It's going to be a journey. Let me use an example. We used to charge in East Africa $4,000 for a permit of a nurse and a doctor working for 2 years across the region. It took the regulators to come together and understand that if we waive this, health will become stronger in the region. Why should I, as the hospital owner, pay $4,000 for a doctor coming from Rwanda or vice versa? The regulators need to change their mindset from a fee service making organ to a service provider organ. Regulators in our country sometimes need a paradigm shift. That's the problem. It's the money that they're making, whether it's duties, whether it's revenue authorities, that mindset needs to shift, and it's shifting. So when the regulators in East Africa came together, they harnessed this and they waived the $4,000 permit. Now, health workers are moving freely between 3 countries without employers needing to pay $4,000 for a permit. It's opened up employment in a dramatic way. The nurses could work in any country rather than being restricted of a certain passport that you hold, which means that the tropical diseases that they are treating, they can treat in any one of those neighboring countries. Look at now the railway development levy or the duties in Uganda and Kenya. They are not harmonized at the moment. IDF, which is exactly what you're saying. With AMA, I think slowly all these will dissipate and the bigger picture of access and availability of medicines will come in place. So my only point, I think, Azuka, to you, that this is a journey. We've got to start. The challenge will be, of course, the bureaucracy, a high-level bureaucracy like any other systems we've had, but we shouldn't stop that. We as partners and stakeholders must assist Africa Union and its structures to be part of the solution and not part of the problem.
Actually, I totally agree. A lot of times when we're looking for a perfect time to start something, we never start. It's a journey, but we start. And I hope the whole continent, the entire continent, would rally around, work together, and let's do this, because again, I mentioned, if everybody's living and putting it up on LinkedIn like an achievement, I'm now a citizen, I'm like, oh my goodness, this is sad. Shouldn't have that happen. There's a lot we can do. And then I go back to the 3 of you, Deji, Yusuf, and pardon me, just Babusi. I'll start with you, Deji. Again, is the issue, I heard Babusi clearly. We need to be able to provide services across the continent for people that need the services. And Dr. Thakker has said it, the whole idea is that we need to look at our regulatory system to enable us achieve our goals. It's a journey, but we need to look at it as a continent, not individual countries, Now, if we're going to look at things like health, we must look at it at scale. If I'm getting good services at South Africa, and I can't get it in Zambia or in Gambia, when the opportunities are there, I think that's what the free trade area is trying to really do, to cut through all directives. But then the issue is data. We have always known it, particularly with our governments. They are always very skeptical about the health data. They don't want their data popping up somewhere that says my 90% immunization coverage is actually 19%. What do we do with it? Who should have data? And when we do have, how do we really be responsible? I would say it's responsible about accessing health data. So my first question is, who should have it? Who do you think should have it? Looking at what we're trying to achieve, is it just government? Should we leave it and then know how to leverage? Or it's everyone that is providing services? And then how, from your own perspective, what can we do to, whether it's using technology or whether it's using regulatory, how can we be more responsible with health data so that we don't have issues along the line? So starting with Deji, then you can jump in immediately after Deji, and then Babusi, you jump in right after. Go ahead.
So, thank you for that, Azuka. This is one of the areas I've been passionate about on data, access to data. My quick answer is the government and the regulatory bodies. Why do I say this? One of the main issues, especially we've had with the regulatory bodies, especially in Nigeria, is that they lack access to patient data, to efficacy data of the drugs. They are still very, very archaic in how they look at approvals of molecules via how you put together dossiers. For example, in Nigeria, it takes close to 6 months to get approvals for a single molecule, as opposed to Ghana, that can be done in under a month. And it's simply because of the very archaic process of putting together volumes and volumes of dossiers that really could be harmonized into a few pages. But because they don't have the data, I'll give a good example. When we, at the beginning of the pandemic, we were the first company to actually bring in testing equipment, test kits, reagents, etc., into Nigeria. And I had to literally use personal relationships to get the approval done in 3.5 months. This was from the Director General of NAFDAC directly. Without her, it would probably have taken 7 months. Now you are looking at a pandemic. You would think that there's going to be an urgency in approval, that this would be done in a few days, actually in a week, considering the urgency of the particular situation. But they didn't have the data. They didn't have access to the data from the FDA, who have actually approved the test kits, etc. The test kits were actually used in other countries. Data on the particular on the false positivity rate was actually published, but they did not have access to this data. The second point is, when I look at counterfeit, the anti-counterfeiting strategies in some of these countries, I will use Nigeria as an example because I helped pioneer the SMS authentication initiative we have in Nigeria now with GSK. We don't have, for example, we know based on the data we've received from some of the pharmaceutical companies, what ports have the highest inflows of counterfeits, what particular states, what markets have, if you're going to do a heat map of the prevalence of counterfeits, particular distributors, entry points, we have all this information, but the government doesn't have it. So it limits their enforcement capability. And if all the pharma companies in Nigeria were actually shared this information, not only pharmaceuticals, but other commodities from tobacco all the way to pharmaceuticals, share this information, it can help target enforcement to these particular areas, and of course, to optimize the use of their resources, because they're limited. So yeah, in summary, it's pretty much at the government and the regulatory bodies.
And the regulatory. Do you agree, Yusuf? Let's see. What do you think? You're on mute.
Yes, I can't agree more with you. In this space, that's one of the headache. So in our case, we are at a very interesting phase with our product. We've after having gone through 3 functionality tests in the UK, we're carrying out demonstrations in Nigeria, and now about to kick off the procedures. Just like the as rightly said, it takes about there is a concession actually for they say it takes about 2 weeks to get an approval. But like you said, we actually in our own timeline we have 2 months. In that space, rather than just saying, oh, well, the concession says 2 weeks and it's going to be 2 weeks. It's never going to be 2 weeks. We understand that, and those are some of the gaps in the system. And a lot of things can really happen if we just execute. When we went to some of the ministries and we engaged them, there is documentation, there is procedures, there's everything in place, but the tools to make those things happen do not exist and will not exist. Hence, it will floor the whole process. I mean, detailed documentations as to how a clinical process trial should be carried out. It's all there. But in terms of executing it, doesn't happen. So it somewhat brings to the thought that maybe this part of the procedure was funded itself, was never the fund to get the work done. So there are gaps in our system, and that's why I was saying earlier that we should be patient. And Dr. Thakker was able to shed more light to that as to the 4-year time that's required for things to get harmonized. It's very, very important. In our case, talking about data, given that we're dealing with respiratory care, one of the things we always measure is the oxygen saturation of the patient, right? To ensure that, well, is the patient getting any better, or should we, change medical care options, or whatever we should do. And that data is the data of the patient. It's not our data, right? So the core data is the data of the patient, but then we take a snapshot of that data to make room for doctors to share and learn. And say, okay, well, I've had this patient, and this is how they're improving, this is how they're deteriorating, and you can actually see that graph, but it's not, useful beyond a pictorial image, which the patient not really approve of, because it doesn't link back to them as a person. It's the raw data is their data, but it doesn't link back to them. But you could say, okay, well, I was dealing with patients ABC, doesn't even need to mention the name, but for learning purposes, to have a cohesive environment whereby doctors across the markets could learn. We've had that in place, and it's quite useful. But
let me come in there. Sorry to cut you in, because you were talking about the usefulness of the data for the patient, but it's even more for the doctor who is going to provide the care.
Yes.
So I would like Babusi to come in now, because again, he's looking at things at that continent-wide, and then there's a lot of patients all across Africa. And what does he think about this whole issue of data, responsible use of data? Who should have it, particularly from his own and where he sees it?
Thanks, Azuka. I agree with both Deji and Yusuf in that I think, people who are making decisions at a large scale need access to this data, and also simultaneously people who are directly responsible for health outcomes on the ground. So when we started Sila Health, we, as mentioned, built an ecosystem of tools around the chatbot, tools that included, low bandwidth browser-based video conferencing tools for virtual consultations, an electronic health records platform that automatically sends follow-up notifications to patients, as well as prompts to increase drug adherence, all via WhatsApp. And these tools drastically improve patient outcomes while reducing the time it takes for health professionals to administer care. And also, when patients are referred to specialists or other GPs on our EHR platform, we securely share this encrypted patient information between providers, which reduces the time wasted by way of requesting physical patient files, as is currently being done on the ground. And also, our virtual consultations, because they are a doctor-patient conversation, are autonomously recorded as part of a patient's record and stored using encryption methods and in line with patient data standards such as HIPAA and GDPR. And what this is showing us is that in terms of gatekeeping data and not being open to innovation within that space due to lack of movement in the regulatory space, we would have definitely reduced our ability to provide care at the scale that we're able to do it at, and also empower doctors to more effectively positively contribute to a patient's health. It's just the idea that a patient would have to wait a couple of days for data to move from one doctor to another if they switch towns. It's just absurd if you look at how this data is currently being stored, and the possibilities relating to where we are in terms of technology and storage of data, and looking at what we are able to do for decision makers. When we built our chatbot, the first product that we built around the chat platform itself was a platform called Trends, which enables non-governmental organizations and governmental health departments to obtain real-time data on reported symptoms and diseases in the areas they preside over. And where this health data is hard and expensive to access, our tool, in a sense, enables these decision makers to quickly identify outbreaks of diseases and also follow general health trends in real time to better evaluate the success or failures of health policies, and also to predict future demand for health equipment and medication by locale. So I think there's a balanced way to approach this collection of data in a way that directly contributes, and directly here looking at the time it takes to do so, directly contributes to patient outcomes, while also allowing people who are able to make and effect change at a higher level with a higher force multiplication to be able to do so with more transparency around what exactly is happening on the ground, and based on our position in this value chain, our ability to collect this data at the scale at which we're collecting it, in the remote areas in which we're collecting it, enabling them to do so as well.
Fantastic. I think we all agree, as private sector, it does sound as if we think, the government, regulatory, those that are going to use this data for outcome in, I would say, interventions, even the patients, It would be interesting to have only a government panel. Then it would be interesting to see or hear what they would say, particularly across, within the continent. So I hear that, but there's something I must disagree with Deji and you, Yusuf, and Babusi. All of you said you agree with him completely, but I do disagree with him in one thing. He said he compared Nigeria with Ghana when it came to approval for the molecules. That's okay, but don't compare Nigeria with Ghana with your jollof rice. So, that one I will not agree. When you are comparing, doing your comparison, Nigeria, Ghana, limit it to those, those approvals, not jollof rice. Having said that, there's a question. Let's go into Q&A. I see there's a question around local manufacturing, and it does say that when we're looking at that, have we considered why that we have the largest graduates of doctors, but these doctors choose to serve elsewhere because of lack of equipment, lack of electronic, digitalized system. And I take it to one of the questions we had in mind to ask, and I'm going to Dr. Thakker. That question is all around, all these innovations. Where do we see medical devices and biotechnology? How do we scale that across the continent so that, again, we retain our talent? If they don't have the devices, if they don't have those equipment, they are going to go where they can use their talent. So Dr. Thakker, how do we see that innovations around devices and technology at scale?
It's a great opportunity. Devices, 17 years of HIV/AIDS, we still don't make our own tests. It's a bit of a concern. Everything we buy is from outside. Every test, everything we do, RDTs we buy from outside. In fact, even glucometers, every glucometer for every diabetic patient on this continent we buy from outside. Every strip for checking sugar is from outside. Now, we got so lazy, and I think pandemic was the biggest wake-up call. It really gave us a shaking. So I think the biggest wake-up call for Africa has been the pandemic, that now wake up from slumber. Too much sleeping to the highest extent, that just because China could supply you and others could supply you, you just use your dollars to buy things. It's now time to change and make these diabetic stuff, devices, ECGs ourselves. When the borders are shut, what are we going to do? Sit there and say, please give us PPEs because we can't protect our doctors and nurses, they'll die? Come on, slumber is over. Okay, so I think the sleeping time is over, and we need to make our own devices, our own strips. We need to make our own ECGs. Now, there's a process, just like manufacturing. It doesn't get done in a day. Fill and finish, learned capacity, try and do things, but have the energy and an enabling environment. Now, maybe governments also need to change leadership, because they like buying. Once you become a minister and you are in government, procurement becomes almost a hobby. And for obvious reasons, procurement becomes a big thing. And that's been one of the largest problems on the desire to procure and intertwined with some very funny contracts happening in all different ways. So that's where the biggest scams of healthcare come. So we need to get away from this, that I'm in my position as government and I need to buy. The more I buy, the more benefits. So that leadership transformation, plus the desire to create an enabling environment and making private sector realize that it's the right forum, there will be an amazing amount of investments in devices, in diagnostics, in manufacturing. Access to healthcare will be better. This continent is ready to shine. It just needs the tweak in that modeling of leadership.
Thank you very much, Dr. Thakker. I really would love to put you before the Africa Development Bank. A lot of times I think they are doing a lot of conferences and good pictures, and I'm like, what? I mean, this is a time to really invest and do something real. And then I want to, the other question, and you said something, how procurement is like, once they enter those positions, hey, procurement is the thing to do. And then I'm beginning to get concerned. And that's one of the executive secretaries in one of our states said to me, what is this Africa medical agency? What is it going to do? Is it going to go into procurement for the continent? Is that really what they should be doing on the AU? Initially, I thought it was a fantastic idea, but then thinking about it, AU, beyond COVID that we had to deal with emergency, we had to go into emergency-wide procurement for the COVID vaccines. Should we go really into this? So going back to Deji, and also I go to Yusuf. What do you think about the AMA? Is it really something, should they be learning? Should they be doing that? Is that what should that be the focus of AU now? Deji, you can tell.
I think it should be the focus of the AU right now. Their purpose should not just be conflict management. I think they have been too bogged down and too focused on the wrong things right now. And a lot of, if you think about the economic, the reasons for a lot of the conflict management that they have to deal with as a result of economic issues. If we're looking at local manufacturing and we're bringing everything in-house, like Dr. Taka said, and we are actually harnessing the power of the collective Africa, they won't have as much time to focus on conflict management. They will be more concerned as to how to continue to grow the continent. But again, it's the governments we have. I'm not sure they are thinking really outside the box. And I think you mentioned something about Africa Development Bank, Azuka, is also one of the frustrations we've had. I think I've had some conversations with them on funding local manufacturing initiatives, especially on out-of-patent molecules. Even with I've given them proposals on manufacturing with the right certifications that we can get the manpower in place, and they're not interested.
Yeah.
So
sorry to cut you. I mean, like, we could stay here forever. I'm enjoying myself, but Regina is playing the timekeeper here. So sorry to cut you in, but I think just to round up, because we really do need to stop at in the next 3 minutes. And I hear you, Africa Development Bank, we need to sit with them really to say, how are you really going to help the continent, particularly in manufacturing, and make it easier. It's really a touch point. But having said that, I want to use the last few minutes. I would have allowed Yusuf to come in, but for the time. But thank you, everyone. Thank you, all the panelists. It has been an amazing time. I've enjoyed myself, and I'm sure the audience have. Thank you, Babusi, and thank you for the great work you're doing. Thank you, Yusuf. Thank you, Deji. Thank you, Dr. Taka, for the insight you have brought on the table. We are Africans, and we are doing great things, and these kind of sessions actually bring it out. What we need to do is to see how we leverage these instruments that have come in, the free trade agreement, leverage the the AMA and strengthen those and encourage our government to put down their own instruments and support it. It's a journey, like Dr. Thakker said, but we need to start taking that journey and learn. You know, we need to acknowledge that we may not get it right, but we keep going on the journey, we keep learning, and we keep collaborating. Public-private partnerships, leveraging strengths. So I will let the floor, I will just have a minute. I'll let Regina or Artie that is here say a final word before we close. Thank you, everyone.
Thank you.